Okay, we're going to talk about chapter 13. What do we do once the baby is born and they're in transition? Transition is the stage where the baby's born and the baby has spent time with mom for a little bit, but baby in transition is going to last usually about 4 hours. And it's just watching the baby and how they're adapting to the outside world. Is everything going like it needs to be going? So that's what we're going to kind of talk about in this one. And how do we care for those babies during those times? Because this is usually kind of your critical period where things are going to kind of go wrong if they're going to go wrong. So it's going to be important that we keep our assessment skills up and we kind of realize and watch things and figure out what's going on and anticipate what could happen with the babies. So as far as physiological adaptation, once that baby's born, they're going to have to really adapt very, very, very quickly to the outside world. So once the baby takes its first breath, it's going to fill with that air. As it comes through that birth canal, most of the fluid in the lungs is going to be squeezed out as it comes through that birth canal. However, if you get a baby that's a C-section baby, that doesn't always happen. So sometimes that fluid can stay in there and they have a little bit more chance for some respiratory issues after a C-section. Now, if there is fluid in there, a lot of times the lungs and stuff will just absorb that fluid, and a lot of times it doesn't cause them any problems. You will get that select baby that will have some respiratory issues afterwards just because there's extra fluid in there. So we want those babies to have that very strong respiratory effort right after that few minutes of life. That's why you'll see the doctors and nurses really rubbing them kind of vigorously, and you think, oh, that's really a lot. But they're rubbing them kind of hard to kind of stimulate that cry, because we want that cry. The more that they cry, it increases the pressure in the lungs. It forces that fluid out of there. And we want, once they cry, it really kind of helps push everything, close all those holes and push those lungs open and get those lungs to start happening. So in order for the lungs to work properly, they have to have that surfactant. The surfactant kind of is what bathes those alveoli and keeps them open and keeps them functioning like they should. So that surfactant is very, very important. And many of your babies, if they're born early, will not have that sufficient surfactant to keep those lungs alveoli open. Even if you have a term baby, let's say you have a term baby and mom had diabetes, and we've got a 10-pound baby that was born at 37 weeks and 7 days, or 37 weeks and 6 days, and you're thinking, well, they're technically almost term, and they're large, but sometimes those large babies don't always do really well respiratory wise afterwards. So even if they look like a good, healthy baby, you really do have to watch them very closely afterwards just to make sure that they're doing what they need to do. So some of the first things, when a baby's first born, the first things you're going to look at is going to be respiratory effort. So we're going to look at that baby. Any signs of respiratory distress, you're going to want to report to your physician. So you're going to look for tachypnea. That's going to be a respiratory rate over 60. Nasal flaring. That's where the little nasal, you can kind of see it flaring because they're actually trying to work at getting more air into the lungs. Grunting. And a lot of times you'll see the parents are like, oh, look at that, the baby, they're making that cute little noise. Well, they're making that cute little noise every time they take a breath. That is respiratory distress. So you want to, and sometimes I've even had to get down there and like really listen to hear that grunting. Any retractions, whether it's intercostal retractions, xiphoid retractions, any retractions at all is a sign of respiratory distress. Unequal movement of the chest. So if you get one side of the chest that comes up and the other one doesn't, any changes where the abdomen and the chest are not working together, or anytime you see central cyanosis. Acrocyanosis is extremely common for the first 24 hours. So a lot of times you'll see cyanosis on the nail beds and on the toes of babies. Sometimes it can even go up their hands. That's normal. That's just kind of getting all those blood vessels opened up and getting oxygen coming through. But central cyanosis is not normal. So if you see cyanosis on the trunk of the baby, that is not normal. That needs to be reported. There's something going on with that baby. They're not able to get the oxygenation. So we look at respiratory first, then we're going to look at cardiovascular adaptation. So we're going to look at that heart rate. They're going to have to adjust very quickly. So in the heart, You got the foramen oval valve. That's going to have to shut between those atria in the heart. You've got the ductus arteriosus. That's the one where the pulmonary artery is connected to the aorta. It's because it's been bypassing those lungs. The lungs have not been working. So it's just been making a big loop around there. So that has to close. The foramen oval valve has to close. The ductus venosus down by the liver has to close. All of that has to close. So we're going to be watching for that. Sometimes you can actually hear murmurs if things have not closed, and we will just double check. And it's not, a lot of times the babies will close almost. So it might have just a little bit more closure to go. So you'll hear the murmur. They'll do an ultrasound and they're like, well, it's in the process of closing. We're going to watch it. So it doesn't always shut down immediately or all the way at first. We like for it to, but it doesn't always. And a lot of times they'll go ahead and just watch that for a while. Once all of that shuts down, their circulation is just like ours now. And all the pressure changes, everything has to change to make that happen. So when that baby's born, takes that first breath, all those pressure changes in the heart and the vascular system is what actually shuts all of those openings down. So the next thing is thermoregulation. So our first thing we're going to look at when a baby's born, respirations. We're going to look at cardiovascular status, making sure that things are starting to circulate. We're listening to the heart tones. Then the next big thing is going to be thermoregulation. How do we keep this baby warm? Can the baby produce heat with the heat loss that it's doing? So a lot of babies will have difficulty with this. A lot of them are very prone to heat loss through, convection, evaporation, all of those types of things. So we're going to have to make sure we're keeping them warm. Babies have a very large surface area on their body compared to what their body fat is. So these babies are going to lose heat very, very quickly. They can get into what we call cold stress. Cold stress is where they're going to start breaking down that brown fat to use it as energy, and we do not want them to do that. So we're going to look for that. Now, a lot of your babies, you will notice when they're first born, they like to be all flexed in that fetal position. They do that because that helps conserve their body heat. So if we look at the next slide, we're looking at how does the babies lose heat. The babies will lose heat in a variety of ways. But if you think about conduction, let's say that when we weigh a baby, we put them on a cold scale. That cold scale is going to bring that cold into the baby. So it's going to be cold. It's going to bring it into the baby. Convection is where air blows over our baby. So if we've got a fan in the room, if we got an air conditioner blowing over the top, that's convection. Evaporation, that is just where the baby's wet and all that heat is going to evaporate out. So we got to make sure our babies are dry. Make sure that, we dry them very thoroughly. Radiation is where there's cold coming in, but it's not really touching the newborn. So it radiates off the baby. So if you've got your baby laying there and you've got a cold window or you've got a cold wall, that's why we tell moms not to put them on an exterior wall, because radiation, that cold, can take the baby's heat and take it away. So we don't want them to be in a cold environment. So they can radiate. So kind of know a little bit about how they lose their heat, because there's probably likely going to be a question about that. Metabolic adaptation. So respiratory's first. We're looking for any signs of respiratory distress. Then we're looking at cardiovascular. What is their heart rate? What do we want it to be? Then we're going to thermoregulate them. Now we're going to look at metabolic adaptation. So we're going to look at all four of these things. Now, the big thing about babies is they need a steady supply of glucose. They've always had that steady supply of glucose inside mom. Mom has supplied it. It's kind of like, I always say, it's like a continuous glucose shop in there, because they have never had to work for glucose. Now they do. Now they're going to have to get that glucose on their own. And the liver hasn't really had the ability to store glucose anymore. Usually the liver stores glucose as glycogen, and the liver isn't able to do that right now, so the babies aren't gonna have that reserve of glucose. So we want that baby's blood sugars to be 45 is our magic number. Anything below 45, we're going to get concerned about. I know the book will say one thing, ATI will say another thing. 45 is usually a good number to remember. So we really want them to be 45 or above. And I know the book says 50, ATI says 40. So I kind of take 45 as our number. So risk factors during pregnancy that can increase our risk of babies having hypoglycemia is if mom had gestational hypertension, mom has maternal diabetes, or mom ends up with gestational diabetes. If they've had a really prolonged labor, if mom's labor has been really, really long, inside there, baby is still becoming very stressed. Even though mom is still giving that baby glucose, baby has been very stressed inside there. So when baby comes out, baby's going to be very stressed. They're going to use up a lot of glucose afterwards. So, we're looking at, if you've had to use oxytocin or terbutaline, all of that increases risk factors for hypoglycemia. So a lot of times at the hospital, there's protocols that if mom is a gestational diabetic, every baby will get a blood glucose within an hour after birth. And so we just kind of follow that. There's a new protocol up there that the babies have to have a glucose if mom fits these parameters, baby has to have a blood glucose within an hour. And then they have to have 2 more every hour just to make sure that they're staying steady. So looking at that, we're going to look at the newborn characteristics too, because we know the way a newborn looks kind of can give us an idea that they're going to be at higher risk for hypoglycemia. So if you get a baby that has intrauterine growth restriction, so that's going to be your small for gestational age babies. So let's say we have a baby that's born 39 weeks, but the baby's only 5 pounds. We're going to be thinking, ooh, something wasn't kind of right. Baby hasn't been getting the nutrition that it needs. So it may have a low blood sugar. We look at those babies that are very large. If mom has had, gestational diabetes, and baby has been on a sugar train for the last, 7 months, that baby's going to be very large, and it's going to be wondering, why am I not getting my sugar anymore? So they're going to drop quickly. If you get a baby that's premature, those babies don't have any brown fat or anything to pull from. And if they have any cold stress at all, there's nothing for them to pull from. So their sugars are going to go down very quickly. So these are just some other reasons that your babies are going to get your hypoglycemia. So early signs, things that you're going to see. Sometimes it's kind of, what I see a lot with newborns is a lot of newborns are very jittery, just because their neurological system is very immature. So jitteriness is one, but one thing that I usually look at is 3 things. When I look at a baby that might have hypoglycemia, I look for the babies won't eat. We just can't get them to eat, and you're really trying to work with them to eat. The babies are kind of like lethargic. They don't really want to wake up, and these babies will have a hard time keeping their temperatures. If you can't keep a baby's temperature above 97.5 and they're not eating good and they're just kind of lethargic, and when they cry, it's this real high-pitched cry, though that would be what I would be looking for my hypoglycemia. So those are some things that you're going to look for. Late signs, we hope it never gets to this, but late signs, those babies are going to start having respiratory distress. They're going to start having periods of apnea that lasts more than 10 seconds. It's not uncommon for babies to have periods of apnea. So like the babies will breathe really fast and really rapidly, and then they'll have a period of about a 5-second apnea. And then they'll breathe really fast, and then they'll have some periods of apnea. That's called periodic breathing. And that is normal for a baby. But if they start getting longer periods of apnea, that is not normal for those babies. If their sugars get down too low, they will actually have seizures. The other day, we had one up there that their blood sugar was like 18. So those are bad. They have no sugar. They have no ability to use that sugar for energy at all. So we have to really watch those babies. Now we're going to talk about hepatic function. So we've done respiratory, cardiovascular, thermoregulation, metabolism. So basically we're looking at respiratory distress, low cardiovascular, so we're looking at like your pulse, your coloring. Then we're going to look at temperature. Then we're going to look at the blood sugars. Now we're going to look at liver function. So inside the baby hasn't really had to work at oxygenating itself. Now once the baby's born, the lungs are starting to function. So now we're going to have red blood cells coming around. So a lot of times these babies will have extra red blood cells because they've got to have it available for that oxygen once the babies are born. After they're born, the lungs start to function. The liver is starting to break down those red blood cells. The byproduct of red blood cells is bilirubin. So if our bilirubin is high or your baby just starts to look kind of jaundice or kind of yellow tinged, we're going to be concerned about that. So a lot of times, and I'm not going to get into the unconjugated and conjugated bilirubin, we'll get into that later on. But just know that that is something that can happen. It's not uncommon for a baby to get what we call physiological jaundice. That is just because they have these extra red blood cells. They've broken them down because they didn't need them, and the liver is very immature. So the liver might be producing immature red blood cells. The body's breaking them down. The byproduct is bilirubin. So if you get a baby that develops jaundice in that first 24 hours, that is not normal. But if you get a baby that gets physiological jaundice, they get a little bit of yellow. Usually these levels are within 3 to 5 days, we're going to see these levels. They will start to go down because the babies are starting to adapt. That liver is starting to adapt. It's starting to do what it's supposed to do. But if you get a baby that, gets extremely jaundice, and at 20, before 24 hours old, we've got jaundice levels of 12 and 15. That is not normal. That is not physiological jaundice. That is pathological. That is a disease process. But physiological jaundice is normal just because the liver is breaking down those red blood cells that it doesn't need. So physiological, normal. So we would like those bilirubin levels to be between 2 and 6. At 2 and 6, you might see a little bit of yellow tinge, but not a whole lot. At 12, you're going to see a yellow baby. So that's going to tell us that that baby might have like the ABO incompatibility. Mom might have an RH factor of negative. So, but we'll talk about that later. This is just the simple liver adapting. Jaundice levels should be between 2 and 6 at 24 hours. So that's what you're looking for. And we've kind of talked about that already. Now, the other thing that we have to think about is the liver also does a lot of your clotting factors. Well, in order for your clotting factors to be jump-started, I guess you might want to say, your body needs vitamin K in order for that to do that. We get vitamin K from E. coli. Babies don't have E. coli yet. They have a sterile GI tract. So they haven't had that ability to make that E. coli yet. So that E. coli can't synthesize or get that vitamin K, the vitamin K to, okay, let me start over. Okay, so when your baby is born, the GI tract does not have that E. coli. E. coli is needed in order to manufacture or make vitamin K. So they're going to be born, they're not able to make that vitamin K. Vitamin K is what makes our other clotting factors, or that clotting cascade. So if we don't have the vitamin K, we can't do the clotting cascade. So every baby's going to get vitamin K at birth. And it's an IM shot that they're going to get for that. Now, some parents are refusing to get the vitamin K shot. If they refuse the vitamin K shot and it's a little boy, they cannot circumcise them for 7 days because they have to allow that E. coli to build up in the colon, to get to the liver, to manufacture that, to kind of manufacture that vitamin K. so that vitamin K can start making those clotting factors. So it's kind of a cascade of things that have to happen. Okay, so behavior and socialization. So once we've got our baby stable, we're going to kind of look at what they look like. Every baby's going to have a temperament. Some of the babies are a little bit more temperamental than others. Some of them are very laid back. Every one of them is going to have something different. We do something called a neonatal behavior assessment scale that just kind of gives us an idea what the baby is like. And so when we do that, we look at these kinds of things. So we're looking at like their sleep cycle. Are they in a real deep sleep, a light sleep? Are they drowsy? Are they quiet alert? Are they active alert? Are they crying? So you look at all those things. Like a lot of times when we'll go in and do our assessments on our babies, before we touch the baby, what does the baby look like? Are they sleeping? Are they awake, but they're just looking around? What are we seeing in our babies? So it is important to remember that every baby's going to be unique, just like we are. Every baby's going to display different kinds of things. So we have to be aware of those sleep-wake cycles. Sometimes those babies want to sleep a lot through the day and they want to be up more through the nighttime. So it just kind of depends on our babies. Now, once we've got our babies, we've determined that their respiratory rate is stable, their cardiovascular system is stable, and we've got them thermoregulated, and their blood glucose levels are okay. Now we're going to assess that baby. Every baby has to be assessed by the nurse within a certain time frame. So we're going to look at them very closely right after they're born. So cardiovascular adaptation, when they cry, is it good and strong? Is it a healthy cry? Is their heart rate above 100? The normal heart rate is 110 to 160. However, sometimes I've seen a baby's heart rate that was like when they're sleeping, it gets down to like 100. And they say as long as the baby looks good and there's no central cyanosis, there's no grunting, there's no tachypnea, sometimes they can say that that could be a normal feature. But we really want that heart rate to be over 100. So once a baby's born, very quickly, we're going to assess that baby very quickly. And we do that with APGAR scores. So an APGAR score is done at 1 minute of birth and 5 minutes after birth. So at 1 minute, we're going to look at 5 different parameters. We're going to look at their heart rate. What is their heart rate? What is their respiratory effort? Are they trying to breathe? What are they doing? What is their muscle tone? So we're going to kind of look at that tone. Do they have good tone? Or are they just coming out and they're just like this, floppy? We don't want to see that. We're going to look at their reflex irritability. What is their grimacing? What are they doing? Do they cry easily? And then we're going to look at their skin color. So each of those parameters, there's 5 of them that we're going to do. Each of those parameters is a 0 to 2. So the maximum they can get is a 10. So what we'd really like to see is an APGAR of a good 8. And then at 5 minutes, we'd love to see a 10. So that's what we're going to look at. If we get a baby and their APGAR score is 4, that's going to tell us that that baby's not going to be good. So if you look at here, your criteria, your skin color, your pulse rate, your grimace, are they crying with stimulation or are they doing absolutely nothing? What are they not doing? And then we're going to look at their activity. Are they flaccid? Are they just kind of floppy like this? Or are they got that good tone? We're going to look at that respiratory effort. So all of that is going to be taken into consideration. So again, if you get a baby that their APGARs are 4, we've definitely got a problem here. So we got to look at that and determine what our babies are doing, and we have to act accordingly to what is going on with that baby. So during that transition, we're going to be looking for all those things, just like we talked about a minute ago. Very first thing we're going to look at is respiratory. How is the baby respiratory doing? How is the cardiovascular system doing? These 2 things are going to go hand in hand. Cold stress. So again, we're going to look at that thermoregulation. We're going to look at hypoglycemia. So those are the 4 big things that we're going to look at after that baby's born. So our admitting exam, we're going to do the APGARs immediately, but that is just a very quick way of looking at the baby and how they're adapting to the outside world. Next, within 2 hours, we're going to do a much more completed exam of that baby. So we're going to look at that baby very, very closely. And usually we're going to let baby spend an hour with mom And then we're going to take baby and we're going to do this exam on baby. Usually we're going to do it under a radiant warmer so we usually have them naked so we can kind of see everything all at one time. So this is usually going to be done within that first 2 hours. We're going to look at mom's history. Did mom's history suggest anything that we need to be looking a little bit closer for? When we do this, again, we're probably going to have them under the radiant warmer. We're going to have them in a very non-drafty area. We're going to have them in good light so we can actually see what we're needing to do. So we're going to when we do this assessment, we're going to do it like we do an adult assessment. We're going to look at them first from head to toe. What are we seeing? What are we looking at? And then we're going to start at the head and we're going to work our way down. So the very first thing you're going to look at is respiratory effort and your heart rate. So before we even touch the baby, before we get them all wound up, we're going to do a heart rate and we're going to do a respiratory rate. So we're going to look at that respiratory rate. A lot of times I can put my hand just on them and we count for a full minute. So I can put my hand on their chest and I can watch the chest rise and fall for that 1 full minute. Then I would kind of sneak my stethoscope in there and I would listen to their heart rate for 1 full minute. Once we get the respiratory rate and the heart rate, I'm not so concerned. I want them to wake up now. I want to see what they're doing. I want to look at them a little bit closer. So once we've established this, now we're going to look at the head to toe. So we're going to do all of our measurements. We're going to do their OFC, which is the occipital frontal thing. We're going to look at that. We're going to look at their chest circumference. We're going to look at their length. We're going to weigh them. We're going to do all of that kind of stuff more thoroughly. So we're going to look at them a lot better than we did before. So we're going to look at their general appearance. So what do they look like? Do they look well nourished or do they look really tiny? Is everything symmetrical on their body? Is their head larger than their body, which it typically usually is because that's how they're going to come through that birth canal. They usually have kind of a short neck. That's why we never check the carotids. Are they in that flex position? Do they have those clenched fists? Does their belly look good and rounded? So we're going to look for all that, just that general appearance. What do they look like? Just like when you walk into your patient's room as an adult, which babies and adults are not even similar, but you do the similar things when you do an assessment. When you walk into your patient, you kind of just look them over head to toe and see what they look like. Then we go specific and we start working our way down symmetrically. So that's the same thing we're going to do here. So respiratory rate should be between 30 and 60. Anything below 30, anything over 60 needs to be reported. Heart rate, 110 to 160. Now, if you got a baby that is just screaming and you get a heart rate of 180, that's probably normal. Wait till the baby's resting, come back and check it again. We should see a heart rate between 110 and 160. A sustained elevated heart rate, we're going to need to let somebody know about that. Temperatures should be between 97.7 and 99.5. And it's always going to be axillary. We rarely ever do a rectal temperature. The only time we would do a rectal temperature is if we got a baby that's really cold and we have done multiple axillary temperatures and they're still saying it's low. We might go do a rectal temperature just to give us a more accurate temperature, but it is not something that we do routinely. It's always going to be axillary. Blood pressure, we don't ever do a blood pressure unless that baby's in the NICU or we feel like there is there's something else going on with the baby. But we would want the systolic to be between 60 and 80 and the diastolic to be between 40 and 45. So an easy way to remember that, you want their blood glucose 45. So just think about your diastolic 45. Okay, and I always think 60 to 80, my blood pressure, I always think of 60 because their heart rate to do after they're born on an APGAR, if it's less than 60, we do chest compressions. So I always think 60 for that, and I always think 45 for their blood glucose. So it just kind of sticks in my head. Weight should be between 5'8" and 8'13". That is considered a normal weight. Very, very, very common for our babies to lose weight. They usually lose 5 to 10% of their body fat within that first 3 days of life. Now, usually they're going to lose that from dehydration, just not getting enough fluids and things like that, and that's very common. Anything over 10%, our doctors are going to get a little bit concerned. They might want to put a fortifier in their food just to give them that extra boost of caloric intake. But usually our babies, once they get back to their birth weight, about 7 to 10 days, that's why babies are discharged, and then usually they have a doctor's appointment within 7 days because the doctor wants to make sure they're back to their birth weight. Then they're usually going to get about 2 pounds every month up to about 6 months, and then things will kind of change again after that. But they're going to gain about 2 pounds a month. So if you get a baby that was 6 pounds, they should be 8 pounds at 1 month. They should be 10 pounds at 2 months. So we want them to gain that 2 pounds a month. Anything under that or anything more, we would want to be looking at something like that. Most of our babies are 19 to 21 inches. I'm not really going to get into the specifics on that, but just know our general kinds of things. If we had a baby that had a larger head, we would be maybe thinking hydrocephalus. Maybe they have a ventricular bleed. What's going on with that? If they had a very molded head, they might not meet this circumference here. So we'd want to look for that kind of stuff. Hair, skin, and nails. When you look at their skin, it should look good. They should have good skin turgor. Their skin might be a little bit reddish at birth. That's all okay. We shouldn't be able to see a lot of veins going through there. It should just be a good skin. You might see vernix, which is the white cheesy stuff on them. You might see some lanugo, which is the hair, and you'll see that a lot of times on their back or their lower back. You might see melia. Melia looks like little white heads, and it's just clogged ducts. Those will go away on their own. Acrocyanosis, where they have the blue of the hands and the feet. Modeling, sometimes you will see a little bit of modeling on the legs or the hands where it looks splotchy blue. Sometimes that's normal. Harlequin sign, I have seen this. I saw it not too long ago, where one side of the body is kind of pale and the other side of the body is pink. That's a normal thing. It will usually go away once all of the circulation starts going. Jaundice. Jaundice is not normal, but a little bit of jaundice is a little tiny bit is a little bit normal as long as that jaundice level stays below 6, just because of the breakdown of those red blood cells. Any birthmarks that you should see, any moles, anything that you see, any skin tags, any birth trauma, any, I always call them like stork bites, where it looks like a little rash. Usually we get those on the top of their eyes, between their eyes, and in the back of their head. Look for all those kinds of things. All of that has to be documented when you're doing this assessment. Look at their scalp. Is their hair soft? Is it dry feeling? So look for anything that is abnormal. Fingernails. A lot of times they'll be born at their term, they'll be born with long fingernails, and they will scratch themselves. So sometimes moms and dads will put little mitts on them. Mitts don't stay very good, but a lot of times we can put socks on their hands. A lot of the little things will come with things to put over their hands. The head and the face, we're looking for symmetry. So look for symmetry with the eyes. Are the eyes symmetrical? Is, all of that kind of stuff. Molding, you're gonna see molding. So these sutures that run through here, if the baby's been born vaginally, sometimes when it comes through the canal, it overlaps some of those sutures and causes some swelling, especially if they've had the vacuum. So you might see what we call caput succedaneum. Caput succedaneum is different than the cephalohematoma. Caput succedaneum is going to be it's going to be like soft on the top of their head, and it's going to go across the suture line. So see your suture line here, how this goes across the suture line? That's your caput succedaneum. Your cephalohematoma is different. This one is where the periosteum is involved, and there's a collection of blood underneath here. This does not cross the suture line. That's how we know the difference between the two. So we're going to look at the fontanelles. We have an anterior and a front, and we have an anterior and a posterior. Sometimes these fontanelles will overlap. They may even come, whoop, 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 I didn't mean to do that. Sometimes these guys in the middle will even actually come over the top of each other just to get that baby through the birth canal. So we'll go back and we'll look at we'll look at the face. Sometimes if they've had to use forceps, they can actually get paralysis of the fifth cranial nerve. So we'll want to make sure that the baby, when they move, it's symmetrical and everything looks normal. So then we're going to look at their eyes. A lot of times their eyes are kind of a gray, kind of a navy blue color. Sometimes, and that will change as they get bigger. Sometimes the swelling of the eyes depends on how fast they came through the birth canal. Pupils are usually equal and reactive to light. Sometimes it's really hard to get those pupils open. I have never, a lot of times it's not uncommon for the babies to have like cross-eyed, very common. Now, I know it says here that they track objects. I've never really seen a newborn track an object because they're just not, they don't know what's happening yet. But as they get a little bigger, they should be able to track an object. They usually don't have tears yet because those tear ducts haven't got started yet. The bridge of the nose, so we're going to look at the nose. Is it flat? Is it symmetrical? Are the nares open bilaterally? Are they patent? Do they have any nasal flaring? Do they have any nasal drainage? Anything that's going on, we're going to look for that kind of stuff. Any trauma. We're going to look at the mouth. Is the mucous membranes pink? Are they moist? Is baby sucking? Is the uvula midline? Do they have a cleft palate at the top? Can they suck? Do they have a gag reflex? Do their cheeks have those good little fat pads? We're looking in their mouth for Epstein pearls. It looks like white little things on the hard palate. Precocious teeth is where they've got very rudimentary teeth. I've never seen those, but sometimes they will remove those because they're usually not in there real good and they can actually cause some problems on choking. So they would remove those. Any thrush, that would be white patches on the mucosa in the mouth. We're looking for the frenulum underneath their tongue. If they get tongue-tied, we're going to look at it up here. That can kind of decide if they're going to be able to breastfeed well. They've got to be able to get that tongue out. So if that frenulum is really tight, they can't get that tongue out. So we're looking at all of that stuff for the mouth. So then we're going to kind of look at the ears. So the pinna, this is the pinna right here. It should be flexible. When we push their ear down, it should flop right back. A premature baby, that won't happen. So we're going to look for that. They will get their hearing screen. Everybody's going to get a hearing screen. If your baby's eyes are low set, so see how that the outer canthus goes right on top of the ear. If you have a baby where the outer canthus, the ear is lower set, we do get concerned about chromosomal abnormalities. That can also indicate there's some kidney disorders. So if we see that, that's something that the doctor will probably want to investigate a little bit to just see what's going on with that baby. So we're going to look at the neck. Is it short? It should be kind of short and kind of thick. They should have full range of motion. You should not see, sometimes we'll get like an Erb's palsy where, if they've had a difficult delivery and we've had some shoulder dystocia, you might see paralysis on that side. You do not want to see that. You don't want to see any masses, no swelling. When you pull the baby up, you want to see that they're trying to pull their head up. You want to look at that. You want to feel their clavicles. Make sure that their clavicles are symmetrical and you don't feel any crepitus inside there. We're going to look at the chest. Does the chest look equal? When they're breathing, does it look like it's equal? The xiphoid process is probably going to be pretty prominent. The chest should be kind of barrel shaped. They might even have breast enlargements a little bit. They might look like they got a little engorgement. That's normal. Are they in the right spot? We have something called supernumeral nipples, where a baby can be born with like a third nipple. That it doesn't cause them any problems, but it's something that needs to be documented. So we look at the breast, make sure they're in the right location. We're looking at the belly, making sure the diaphragm is going up and down. It should be soft. It should be, everything should be palpable. We're looking at the umbilical cord. Is it well formed? Does it have all three vessels? Does it have the two arteries and the one vein? Is the clamp tight? Is the clamp securely clamped? Do they have, everything? Is there any drainage coming from that umbilical cord? So we're going to look at all of that with that abdomen. Genital urinary. Baby needs to void within the first 24 hours. So we're going to look and make sure that the baby's peed within that first 24 hours. If it hasn't peed, we're going to have to go kind of look and see what's going on with that baby. It is not uncommon for female genitalia to be very swollen and look kind of just swollen inside there, and that's normal for that to happen too. Sometimes the labia and that clitoris can actually be coming on the outside, and everything just looks swollen. That's normal. That will all get better and go away. Pseudo menstruation is something that we do need to prepare moms that have little girl babies. Sometimes because of the cessation of all the maternal hormones, mom has had all these female hormones going inside her, progesterone, estrogen, all these female hormones, and now they've been cut off. And sometimes little girl babies will have a little bit of blood in the mucus, and that's totally normal. It's just because of the cessation of all those female hormones, and that's normal. So we'll see that. Now, males, we want to look at where the urinary opening is. If it's on the upside or the downside, we can have epispadias, hypospadias. So we're going to look for that. We're going to see where their little testes are. Are they in the scrotal sac? If not, where are they at? Are they in the inguinal canal? Do they have a hydrocele? Do they have one testy bigger than the other? So we're going to look at all of that stuff. Now, when you pull the little foreskin down, we don't ever want to pull it down and leave it. You want to pull it right back up, because sometimes that foreskin can get tight and actually cut off some of the circulation. So the foreskin should be kept on top all the time. You can look at it, clean it, and pull it right back up. So you want to look at all those things. If your baby has any of the epispadias or hypospadias, they will not be able to circumcise them until that is corrected. Extremities. So you should see that good posture. It should be flexed. They should have that good tone. So when you pull that out, it's going to recoil right back. You pull their leg out, it's going to recoil right back. You're going to look for your pulses. So you're going to look for your brachial pulse. You're going to look for your femoral pulses. You're going to look for all that. Do they have full range of motion on all four extremities? So you're going to look at all of that kind of stuff. Do they have 10 fingers, 10 toes? Do they have any webbing inside there? Sometimes you'll get polydactyly, which means that they'll have an extra finger. We look at simian creases. Simian creases, you should have two creases. You should have one that goes this way and one that comes over here. I don't think you can see my hand, but you should have two creases. If you have one that goes all the way across, that's called a simian crease. That can be something that is abnormal. We had a baby born the other day that was born with a thumb, but the thumb, I don't think it had any cartilage in it. It was just like hanging there as like an extra appendage, but I don't know what kind of movement that baby was going to have. So we look at their legs. A lot of times their legs are kind of bowed looking. They will have flat feet. We're looking at their creases. We're looking at for any club foot, anything like that. We're looking at for clicks for their hips. So we're doing these maneuvers. We do the ortolani maneuver, and we do the Barlow maneuver, where they just bring their legs up and they wrap them around and abduct them. And they're just trying to see if they have any hip clicks or they feel anything clicking inside there. If we catch the hip clicks and things early, a lot of times we can put them in certain little casting things, and it can heal that, and it doesn't usually cause them too much problem afterwards if it's caught early. So then we're going to turn the baby over, and we're going to look at the spine. Is it straight? Is it flat? Do they have any masses? Now, one big thing we look for is a pilonidal dimple, and it's at the top of the sacrum, right where the sacrum kind of comes down and the spinal cord would come down. Sometimes we have like I said, a pilonidal dimple there. Sometimes there will be tufts of hair coming out of it. We had a baby born a couple months ago that had like big tufts of hair coming out of it. And they went ahead and did an ultrasound to make sure that there wasn't a connection between the spinal cord and the outer surface, because that could be like a missed myelomeningocele or something like that. So we want to make sure that that is accurate. Now, how do we know that they have a patent anus? If they poop, it's open. We want those babies to poop within the first 24 to 48 hours. We will not send a baby home unless it has pooped. So every baby has to. We had a baby last year that did not poop, and it ended up having a bowel obstruction. They ended up having to send him to St. Louis. So we have to make sure we're looking at all of that. So every time you go in to check with your moms, have they peed? Have they pooped? Ask them when was the last time they fed? All of those questions are going to be important to ask them. So neurologically, so we, within that first 2 hours, of that transition, we have physically looked this baby over from head to toe. Now we're going to look at their neurological status. So we've done the physical, now we're doing the neurological. And so we're looking at their general appearance. Are they quiet when you first walk in, or are they screaming and crying? Your babies that are coming off substance abuse, a lot of times those babies are just crying all the time, and you will get them quieted down, and then they will just jerk and they will just start crying and screaming again. So you're looking for those types of behaviors. You're looking for anything that is a little bit different. Can they maintain that flexion? When you pull that arm back, does it flex right back up? Are they crying? Is it a real high-pitched cry? Is it just a regular cry? What are they doing? Do they have hypertonia, where the tone is really poor? Do they have hyper, where they're just really up here and we're looking for tremors? Do they have that high-pitched scream? Any seizure activity, anything like that. So you're looking for anything that looks abnormal. You're going to look at all their reflexes: grasping, sucking, swallowing, stepping, Moreau, Babinski. All of those reflexes we're looking for to make sure that all those reflexes are intact. Your baby should be sneezing, coughing, blinking. If you're doing something they don't like, they should be trying to pull away. So you're looking for all of those kinds of things that we're looking at with the babies. So we're looking at behavioral. How are they interacting with the mom and dad? What does their behavior look like? Is the mom and dad know what cues to look for? For feeding, with the babies chewing on their hands, if the baby's sucking, if the baby is irritable, is the parents looking at those cues? So we tell them to start looking for feeding cues. If they're chewing on their hands, preferably we want parents to feed babies prior to them getting upset. So we want them to start looking for cues to feed before they really get upset. So we're wanting moms and dads to look at those. Starting, how are they behaving with the baby? So we're looking at that. And then we do a gestational age evaluation. We call that a Ballard score. The Ballard score, they're looking at physical characteristics, and then they're looking at neurological characteristics, and we're giving them scores for those. So it's an RN's responsibility to do all this, but an LPN can be involved. So I know this is a super long chapter. I sure hope you guys took a couple breaks. But that's it. That is your end of your chapter.